particular clinician has in their hands or what I have in my hands. If I use that tool the wrong way, if I hold the wrong handle of the hammer, it's probably not going to work as well, right? So it is understanding the physiology, understanding what tool might work best, and using that tool optimally. That is what's going to give us the best outcomes. So physiology matters. Everybody would like to have a simple formula. Everybody wants, how do you use this ventilator? And my answer, just as David's, is it depends. Who is your patient? What's the disease process? What's the primary pathophysiology that I need to address? If I have a baby who's not oxygenating well, maybe I should go on my median airway pressure. And that will work if it's atelectasis. But if it's pulmonary hypertension, the lungs are already overexpanded, and going up on my median airway pressure will be counterproductive, right? So physiology matters. If my CO2 is high because my baby has a stiff chest wall, maybe his abdomen is distended, diaphragm's pushed up, I probably want to go up on rate on conventional ventilation, or maybe go up on frequency on the high frequency, because that's the most efficient way to ventilate that baby. But if my CO2 is high and my patient is a baby with BPD or meconium aspiration, who is air trapping, going up on the frequency or rate is going to be counterproductive. So it's all about the pathophysiology, and it requires exercising our little gray cells, and there's no other way around that, so I'm just going to have to deal with it. So to really put things in perspective, we are dealing with some of the most difficult patients to ventilate. Children are not just small adults, we all know that, and in fact neonates are not just small children, especially preterm neonates. They have very much unfavorable lung mechanics, limited muscle strength and endurance. They have very immature respiratory control, and that's a very important element in how they interact with ventilators. They breathe rapidly, they have short time constants until they get long time constants because they have chronic disease and they're older, and they have high endotracheal tube resistance. We need to deal with all of those things. And of course, we use uncuffed endotracheal tubes with frequently a significant leak around the endotracheal tube. And when we talk about tidal volume measurement and tidal volume targeting, you got to be able to measure the tidal volume accurately. And when you don't measure the tidal volume in the right place, i.e. you measure back at the ventilator, the numbers are completely fictitious. So that's a problem that we need to overcome. And devices that are not specifically designed for neonates don't do as good a job as devices that are in fact engineered to deal with some of these unique characteristics of the neonatal population. And of course, this is sort of more of a visual display of some of what I just mentioned. And so these babies are in trouble right out the chute in the delivery room because of these same problems. The lungs are filled with fluid, most of them born by cesarean. They may be a little depressed, they have limited muscle strength and endurance, excessively confined chest wall, the things we talked about. So they have a difficult time both clearing lung fluid and establishing and maintaining FRC. So we need to deal with those issues. And there's much interest in sustained inflation, and Georg and his group here are involved in the SAIL trial that is looking at whether sustained inflation in the delivery room is the right recipe for dealing with this. The same sustained inflation may not have the same benefits later on. We don't know. Some people do use sustained inflation to recruit lung volume at 2 days of age or 12 hours of age. That may or may not be the same result. But of course, it's not just the lung in the neonate. Soon after birth, we're dealing with the transitional circulation. So oxygenation isn't just about the lungs. It may be our pulmonary vascular resistance. Again, the chest wall really gets babies in trouble, even in the absence of surfactant deficiency. They have trouble maintaining adequate lung volume because the rigidity of the chest wall is just not sufficient to maintain that immature respiratory control is a big deal. And certain modalities that may be ideal for a little bit older babies may be a little bit problematic in very mature babies. And of course, we allow our babies to be awake and breathing, at least most of us do, because of some very good data suggesting that being too aggressive with sedation and paralysis makes matters worse. So we do this, but it does make life more difficult because of the way babies interact With the ventilator, they're always perturbing the equilibrium. And they, of course, have a uniquely sensitive cerebral circulation, so stuff we can get away with in older children, we can't get away in neonates. Your 2-year-old isn't going to bleed in his brain when his CO2 drops to 25, but your 25-weeker might. And of course, finally, it's the cardiorespiratory interactions that we don't often pay enough attention to. I talked a little bit about that during the recruitment demo, and you certainly do mess up the circulation when you overexpand things. They're not always easy to appreciate, those interactions, but they're commonly there and often overlooked. So I made the point before that pulmonary vascular resistance is lowest at normal lung volume. It's increased with atelectasis, and it's increased also with overexpansion, and that's clearly seen there. So if you have a baby who's not oxygenating well, you have a little preemie whose x-ray looks like that one over there, and you call your cardiologist to do an echo because you're worried about pulmonary hypertension, I can guarantee he's going to find it, because you're going to have pulmonary hypertension in a lung that looks like this or that looks like that. And so it's a physiology. So understand what's going on, how this is impacting oxygenation. And it's only when you normalize lung volume and there still is pulmonary hypertension that you should be considering vasoactive agents and stuff. You can cure most pulmonary hypertension by optimal ventilator management, something people don't often appreciate. So what about some of the other aspects? So I love NAVA in full-term babies, probably older children. I love non-invasive NAVA. I love the trigger. Howard explained very nicely how much better triggering by diaphragm activity is than by flow or any other method. I love the ability to monitor the respiratory effort that the baby has. It's a way to see what we don't always fully appreciate by just looking at the baby, although you can see some of that. Is the baby retracting? So you have actual numbers. So the electrical activity of the diaphragm is very helpful. But so there is a different approach between volume targeted ventilation, and that's what I will call a paternalistic approach. We know what the right tidal volume is, and we're going to regulate that. So if the baby hypoventilates, back up to point that. So here is your electrical activity of the diaphragm, and here is what the ventilator will do. With volume targeted ventilation, the baby generates very little, hypoventilates, becomes apneic, the ventilator steps up the pressure to try to maintain a stable tidal volume. When the baby briefly has a burst of hyperventilation, as they do, the ventilator will back off. NAVA, on the other hand, gives control to the baby, and when the respiratory center is mature, it's a great way to ventilate. I'm a little bit concerned, it's a theoretical concern, hasn't been borne out, as Howard pointed out. There is no evidence of harm, but there is the potential, at least, to exacerbate this periodic breathing, because this is how preemies breathe. And they have a burst of respiratory effort, and then they have a pause, and then have another burst of respiratory effort. And so, things go up and down. And with NAVA, it's a positive feedback. The baby breathes a little, gets a little support. The breathers not enough will initially get numb, and apnea and ventilation kicks in. Baby breathes vigorously, the baby will get more support. I wish I could be fully confident that it's baby being so smart that he knows that he needs to recruit his lung volume, as opposed to just having this immature periodic breathing pattern. So I'd love to see a little bit more data on tidal volumes that are generated with NAVA measured at the airway opening. So I'm not saying it's not a good approach. I just haven't seen quite enough data to make me convinced that I have at least a theoretical concern about the breathing pattern. So the immaturity of the respiratory control center, I think, has to be taken into account. NAVA was not initially developed for preemies. It has been applied to preemies, and I'm still a little bit of a skeptic. Non-invasive, not a lot, and we're working together on that protocol because I think non-invasive is the way to go. It makes me less worried about overshooting. I know you can put limits on the peak pressure, and with an open system, with non-invasive doesn't worry me so much. But you know, these are some actual data from Dr. Sinnerby, who has been working with this for a long time. And you know, I guess here they didn't have much of a limit. So here's the electrical activity of the diaphragm from a preemie, and you can see, you know, very little, no support, not much going on. And the baby briefly breathes rather more vigorously. The pressure gets up to mid-20s. Okay, not too bad. Baby hypomyelinase drops. And then this baby, somebody aggravated the baby, or touched them, or talked too loud. Babies, and I've watched this with volume guarantee on targeted ventilation. Little buggers can generate 20 per kilo tidal volume if you bother them. And then you put positive feedback on top of that. That worries me a little bit. This pressure is getting, you know, kind of high. So I don't know. I think for non-invasive it's great. I remain to be totally convinced that we know fully what we're doing, and that the baby is quite as smart as we would hope that it is. But that said, more data needed. So, you know, we have to remember that with synchronized ventilation, which of course now certainly is, but all other modes of ventilation are now synchronized, the tidal volume that you get is the result, is the sum of the negative inspiratory pressure of the baby plus the positive pressure generated by the ventilator. And that's the transpulmonary pressure, and that's what gives us the tidal volume. Of course, we don't measure this. We only see and measure this part. So for those of you who like to look at your lung mechanics on the ventilator, if your baby's breathing actively, those numbers are fictitious. They're humbug, because we're not measuring the whole transpulmonary pressure. Graphics are extremely important for seeing whether your inspiratory time is adequate, expiratory time is adequate, all of that stuff, very important. Don't, for a moment, please don't think that I'm poo-pooing graphics, they're very important. But we're not getting the full picture because we're not measuring this. And since we allow our babies to be awake and breathing, this is a very important component of what in fact goes on. And so this is what it translates into. I drew this in here by hand. So this is your standard pressure waveform. Here's your flow that goes along with it, and here's your tidal volume. So we measure and display what's in black. We don't measure, we don't display, we're not directly aware of the spontaneous effort that add the baby's negative inspiratory effort on top of the positive pressure from the ventilator, generating this transpulmonary pressure. And so there are these large fluctuations. Here the baby didn't contribute, so the tidal volume is not so large. Here the baby made a strong inspiratory effort, and the tidal volume jumps up. And that's what happens with synchronized ventilation, whether it be, so in this case, obviously it would be sort of an SIMD or assist control where the baby goes apneic, right? So babies do not have a reliable respiratory drive. So they pause in their breathing, and their tidal volume does fluctuate all over the place. And that's the nature of the beast, but you need to understand these interactions if you're going to make sense of what's going on with your baby. So of course, to make matters worse, we're not dealing with just RDS, and different diseases require different strategies, and the same disease at a different point in time require different strategies. Same disease may have different phenotype. Meconium aspiration is a prototype for that, right? Meconium aspiration can lead to a very homogeneous pattern with mostly surfactant inactivation. The chest X-ray looks homogeneous. It's a relatively similar process to surfactant deficiency RDS, because that's what it is, surfactant inactivation. On the other hand, it may be very much different with thick meconium, a lot of particulate matter with airway obstruction. So different phenotypes. So not all babies with meconium aspiration are to be ventilated the same way, because meconium aspiration can be a different disease in different babies. And as I said, they evolve over time. So all of these things need to go through your mind as you're deciding how to ventilate your patient. And pathophysiologies may coexist. Very often you have A-leak and atelectasis. That's tricky. You can have pulmonary hypertension and surfactant deficiency. You can have a number of things. And again, those cardiorespiratory interactions that we don't always fully recognize and appreciate. And this is one of the many slides I have, to various degrees, plagiarized from Evan Richards, who is a great artist who has done a lot for the education of the neonatologists and respiratory therapists over the years. But what this illustrates simply, and of course I always change things, but he'll recognize it. But what this shows is, of course, that when you overexpand the lung, and notice this is, okay, so this is not the latest version. So I changed this. Oh no, elevated intrapleural pressure, that is correct, I'm sorry. Excessive mean airway pressure. If the PEEP's too high, mean airway pressure is too high, that gives us elevated intrapleural pressure, because if the lungs are stiff, pressure is not transmitted that much to the mediastinum, and you may not see hemodynamic impairment at a peak pressure that's moderately high. You may see impairment of venous return with a lower pressure in a baby whose lung compliance is a lot better, and in fact you are, and your mean airway pressure is excessive relative to this particular baby's needs. So excessive mean airway pressure, this little thing keeps getting in the way. So when your mean airway pressure is excessive, you're going to have a lot of transmission of pressure to the great veins. The heart gets squished. You have impeded venous return from the head, which can of course increase risk of intraventricular hemorrhage. And of course you're going to have impedance of venous return from the legs. And over time, that increased hydrostatic pressure is going to give you edema, which will of course again make matters worse. And all of this decreased cardiac output with decreased venous return and increased venous pressure will affect your cerebral perfusion pressure. So overexpansion is not a good thing, and we need to be careful to avoid that. And then of course, airway resistance changes. So David talked about babies with RDS, they're great, they have short time constants, they're easy to ventilate, you can ventilate them rapidly. And that's absolutely true, but things change over time. And as a baby gets older, that nice tight flow volume, pressure volume loop gets a lot more rounded. And it happens actually a lot earlier than 12 days. You begin to see increasing airway resistance as early as day 4 or 5. And that means changing time constants. That means pay attention to your expiratory time to avoid air trapping, pay attention to your inspiratory time. So pathophysiology evolves over time, and the right settings on Wednesday may not be the right settings on Friday. So we need to reevaluate and make sure we know what we're doing. So this was actually, I discovered somewhat belatedly, it's supposed to be mostly about conventional, but I will briefly mention a couple of things about high frequency, just to point out that there are different kinds of high frequency ventilation. They have different operating characteristics and different optimal frequencies. So for example, the jet, because it relies on passive exhalation, generally requires somewhat slower frequencies. That's not inherently bad or good. That's the way it operates, right? And it has very short inspiratory times, and IE ratios are such as they are, very short, which is probably some important advantage for how we, for treating airway. But a couple of things you need to remember. One is because the very short I time, the mean airway pressure is only a tiny little bit above your PEEP, so you have to use PEEPs that are higher than what you'd ever set on a conventional ventilator. And that's one important thing to remember. But the second is, do pay attention to adequacy of expiratory time. So when I was a young man and very shy, but there was an eminent neonatologist, Dr. Bancalari, giving a presentation, and he compared the jet and the oscillator at frequency of 15 hertz, and he found that the jet caused air trapping, and therefore the jet was not a good ventilator. And I'm like, really shy, excuse me, but wouldn't it be better to compare these devices at their optimal frequencies? Because 15 hertz is clearly not an optimal frequency for the jet. So you know your device, different operating characteristics, know what works. So, Evan, you seen this picture before? Yeah. So I started playing with high frequency when I was a fellow in Akron in the 1980s. Cool gizmo. You could dial in all kinds of things. But anyway, things have progressed a little bit since then. This is the modern version. There are lots of benefits that you already heard about from Evan and Greg. So we have lots of different devices at our disposal. Some of them are only high frequency devices, those two. Others can do both conventional and high frequency. There's some advantages to that. It's nice not to have to change machines, just change modalities. On the other hand, it makes people prone to change too frequently. I was telling my work groups, a little workshop, how neonatologists are not by nature patient people, and that some of my colleagues are prone to make 3 switches of ventilators in half an hour when it's not working. It's not working. I'm like, no, you don't understand how to make it work. But yeah, different. So, different devices, different tools. They're just tools. It's not that this machine is not working. The way I'm using this machine is not working for this patient. Let me think about what's going on. Let me figure out about the physiology. And David and Georg and some of the veterans in this group can pretty much make any ventilator work for any baby. Some might be better at it than others, ventilators, in particular tasks. But if you really understand the machine and your pathophysiology, you can make it work. But thinking the machine that does best for a particular disease certainly makes some sense. So, there are different kinds of diseases. I'm going to talk a little bit about sort of the key characteristics of these kinds of disease processes and how maybe we should think about ventilating those babies. But again, each baby is going to be a little bit different. So everybody's got their own classification of different kinds of diseases and call them a little bit different things, but this is how I approach it. So there is this allostatic lung disease. People call it homogeneous. It can be made homogeneous, but it doesn't start out homogeneous, as I'll point out in a moment. Then there is the so-called non-homogeneous, and the prototype, of course, is RDS. Non-homogeneous lung disease, things like recurrent aspiration, bronchopulmonary dysplasia, we all know what that means. They're very multi-compartmental. Then, of course, there are the air leak syndromes, which typically coexist with other things. And then there's what I call obstructive lung disease. Some people call them restrictive lung disease, but basically airway obstruction, increased pulmonary airway resistance. Then there are the hypoplastic lungs, and then there are the babies whose lungs may be okay, but their chest wall, which includes the diaphragm, don't move very well. So let's talk about them briefly in turn. And so what do we have here? We have a baby with RDS. Everybody knows babies with RDS look like this, and they're relatively easy to ventilate. We love high frequency's ability to use high mean airway pressure without high peak pressure. But again, the goal is to get the lung open. It may be easier to do that with high frequency, at least psychologically it is easier. In practice, it can probably be done both ways. There's different kinds of recruitment maneuvers that we talked about. And high frequency makes a lot of sense because of the short time constants early on. I'm not quite as convinced that keeping babies on high frequency for 2 or 3 or 4 weeks still offers an advantage because the pathophysiology has changed, but some people do it. And the lungs are relatively easy to make, homogeneous, uniformly inflated, and it's a relatively easy disease to manage. But it's not homogeneous to begin with. So here is, half of you saw the allostatic lung and how it does not have microaortosis uniformly distributed throughout the lung as you would think looking at this x-ray, but rather it has allostatic portions, usually dependent regions, and it has aerated portions. And the problem, of course, is that You have lots of injury going on in these various regions of the lung. You will have surfactant inactivation going on in the alactatic portion of the lung. You have shear forces at the boundary here between aerated and unaerated. And you have volutrauma going on here because the critical opening pressure of these alactatic alveoli is much higher than the pressure needed to overdistend what's already open. And therefore, when you ventilate with a total volume of, let's say, 5 per kilo, and half of your alveoli are collapsed, the remaining lung is ventilated with the equivalent of 10 ml per kilo, which we know is injurious. And in fact, animal studies have shown that the most injured portion of the lung in these experimental animals was this non-dependent region, for reasons I just explained. So we need to do something to fix this. We do understand the process, and David explained it in some detail and going over it in the workshops. So we start off with that alactatic. We're now kind of moving time-wise from left to right. We try to get from the inflation limb to a full recruitment maneuver, transient overexpansion, then slide down the expiratory limb and try to find the sweet spot just before the closing pressure to maintain uniform inflation. And typically you end up on a substantially lower mean airway pressure than where you started, with much better oxygenation and importantly, homogeneous, uniform distribution of the total volume. And that's probably the single most important piece of lung protective strategy, next to regulating total volume to some reasonable level. And so here is, however, of course, so this is where we're trying to get, and the demonstration here is that, you know what, it's really easy to de-recruit. You see how rapidly that lung goes back to its alactatic state. So I rather discourage our nurses from disconnecting babies from the ventilator, reposition them, and certainly suctioning is the worst thing. If you don't have to suction, don't, because that's a bad thing. But this also makes the point that all this is recruitable lung volume, and you just saw that. It's not just water. So, homogeneous lung disease, piece of cake. Strategy matters, more information about that. So this was two randomized trials done in the mid-90s. One in Philadelphia, a single center study. One was a multi-center trial that I was running. And at the same time, in virtually the same population of babies, you can see mean birth weight was very, very similar. And the results were diametrically different. Same ventilator, same population, different strategy, very different results. So Tom's data not only failed to show any benefit, but there was some very bad outcomes I showed you briefly before, and we found the opposite. So again, the importance was strategy, different outcomes, same ventilator. So it's not the ventilator, it's who's running it. Now I don't know why, but my x-ray went blank here. So I apologize. This place is bewitched. I don't know what because this is my computer now. So I can't blame his computer. And when I was looking over this morning, the picture was there. Now it's gone. Don't ask me why. There's something in the air here. Yeah. So what you imagine a bad aspiration, meconium aspiration X-ray. You all know what it looks like. You're not missing out. So what do we have here? What's the problem? Well, we have these highly variable, very different regional compliances and time constants. We have slow compartments, we have fast compartments. Some are over-distending, some are alactatic. Very prone to air trapping, so the increased airway resistance. We often have coexisting pathophysiologies, which changes over time. And of course, we very often are dealing with hemodynamic impairment. So this is a bitch to ventilate. This is a tricky lung to deal with. I don't think we really have clear data as to what's the best strategy. High frequency may work, conventional may work. We have to be careful. Lung volume recruitment, the same way that we do with the atelectasis prone lung, is not quite the right answer in the very multi-compartmental lung. So we kind of try to maintain a modest level of distending pressure, but not get too crazy about it. But adequate end expiratory pressure is important to avoid that ball valve air trapping. So conventional wisdom for Meconium aspiration was to use very low P. Why? Because you tend to see air trapping. But the air trapping is of the ball valve variety. It's not over-distension due to excessive set P. It's, if anything, dynamic P. So slower rates will allow adequate expiratory time, so you minimize the air trapping. But you want some moderate level of P to prevent the airways from collapsing around the chunk of meconium. So very low P is a bad idea. Slower rate, absolutely. Whether using conventional ventilation or high frequency, much slower rate than you would otherwise use. There's some benefits of high frequency, perhaps, but not very convincing. And we really haven't defined by randomized trials the best sort of thing. But looking at specifically high frequency outcomes, you know, while relatively homogeneous conditions like RDS, great response rate, not so great with meconium aspiration. Similarly, these are other data with the oscillator. The previous one was the jet. So these data came from Philadelphia using the jet. These data are from I forget where, but using the oscillator. Again, great response rate for RDS and similar with pneumonia, not so great with meconium aspiration. So you're on your own whether you use conventional or high frequency. It's not clear which is the better tool. But again, high frequency used well is better than conventional used badly, and the other way around. Conventional ventilation used effectively is going to give you better results than high frequency used the wrong way. Well, air leak syndrome I have a little bit to talk about. So we have obvious problems, very poor compliance. They tend to air trap, incomplete exhalation, almost always some degree of hemodynamic compromise. In the bad old days, we used to get kids referred to us for jet ventilation from when I was at Georgetown, from Baltimore and elsewhere. These ridiculous settings, diaphragms literally inverted down to the iliac crest. We don't get it quite as bad these days, but it can be a difficult lung to ventilate if you have pneumothorax and with conventional low-rate ventilation, you have a lot of air coming out of those chest tubes. Maybe not such a great thing. But the problem is that PIE typically develops in lungs that are atelectasis prone, and there is some degree of atelectasis, and people sometimes don't appreciate that being too aggressive about trying to resolve the air leak is going to cause a lot of atelectasis, which will in turn require higher pressures to reopen once the lung collapses. So whichever modality you use, generally we try to be very minimally aggressive in terms of using the lowest possible inflation pressure, moderate PEEP. We used to use very low PEEP. Now again, recognizing that if you drop your PEEP too much, you get atelectasis, we are more likely to use a moderate level of end expiratory pressure, especially with the jet. Obviously, we're going to be somewhat less aggressive in terms of target PO2s, recognizing that the cost of getting it better may be too high. Same for CO2, except higher FiO2, because lung volume recruitment, aggressive lung volume recruitment is clearly not the right recipe for this lung. But if we're too low, atelectasis gets worse and we're behind the 8 ball. And there are pretty good data, if I say so myself, that air leak syndrome may be best treated with jet ventilation. And I will briefly share this with you, although it is ancient history and comes from an era that perhaps we don't see these kinds of babies quite so much anymore. But this was a multi-center clinical trial done in the late 80s. Severe RDS PIE. These babies were obviously sicker than what we typically see today. And There was already enough evidence that jet ventilation may be of benefit that no one was willing to do a trial to the death. So we did allow crossover, and we were of course criticized for that. And a pair of PhD epidemiologists did a meta-analysis of the one trial and concluded there is insufficient evidence that it does any good. I don't know if you've seen that. I was a little miffed about that because people with no clinical knowledge telling us that we should not have allowed crossover. I guess so we're going to let him die? Come on, man. Anyway, so I'll show you the data very briefly. So these were 6 kids. So we did show that overall, obviously when you start subdividing into subgroups, you lose statistical power. The trend was there for all of them. Only one subgroup reached significance. Overall, there was a pretty dramatic difference in success of treatment, which was defined as significant improvement or resolution, and was of PIE, and it was highly correlated with whether you lived or died. So we thought there was some validation to those success and failure criteria. If you succeeded, you lived. If you met failure criteria and could not be rescued by the alternate therapy, you mostly died. So it was, I think, not entirely unethical for us to allow crossover, but you can't please everybody. People who have not been to the bedside may not appreciate the limitations of clinical research. This just shows what happened after crossover, having said that we allowed it. So if you failed conventional ventilation and were switched to jet ventilation, this was the result. About half of them improved and met success criteria. About 40% at least transiently improved gas exchange, improved radiographic appearance, and only 16% had no response. When you failed jet ventilation and were switched to conventional, you mostly continued to fail. And I showed you the relationship between success and survival. So why does high frequency, again, this is Evan's artistry, seem to work for air leak, whether it be in the larger airways as illustrated here, or in the smaller peripheral airways? Well, with conventional ventilation, pressure is distributed throughout the tracheobronchial tree, and it's applied in all directions. The pressure in here goes every which way. So when you have a rent in the airway, the gas will take the path of least resistance, which typically is out the hole. With jet ventilation, with its unique flow characteristics where the jet stream flows down the center of the airway, and I hope, Evan, you're showing them how you can jet at a distance. You can actually disconnect the tubing and aim the jet from a centimeter away, and you are actually going to ventilate effectively. So you can jet right past the hole, and we've done it in the lab. You can cut a centimeter diameter hole in the trachea of a rabbit or whatever, and jet right past it, no gas escaping on what little might be the expiratory gas. So there's some physical laws and characteristics of the flow that validate why jet ventilation probably is the treatment of choice with air leak. Conventional ventilation, if you use it, you would want to use it with short dive times and rapid rates and minimal pressures. When you don't have jet at your disposal, people have tried using shorter RE ratios, like going to 1 to 3, which some of the newer oscillators can do. Whether that is equally effective is unclear. There isn't a similar study that proves it. There's also good evidence. This is now looking at big holes, holes in the large airways. Felipe Gonzalez many years ago measured flow through chest tubes on conventional ventilation and then switched to jet. So each patient does his own control, and there was a significant reduction in leak through that endotracheal tube, through that chest tube. We had some fun with a scenario of a very immature baby back in the early 1990s who had it was a 25-week, it was a large TE fistula, and not very good gas exchange, and the belly out to here because it was a big fistula. So deteriorating ventilation. So great, call the surgeon. Surgeon comes in, puts in a decompression gastrostomy. Everybody's happy except the baby, who is now losing half each tidal volume out the gastrostomy tube. So what to do? Well, we need the jet. But before we turn on the jet, I quick measured a little bit quick and dirty, just an inverted, calibrated cylinder stuck underwater. See how much air in 60 seconds came out on conventional ventilation, and switched to the jet. And so what we saw was obviously improved gas exchange, and not only that, of course, lower mean airway pressure, and of course quite a substantial reduction in flow. There was still some flow escaping, but certainly less. And so, and there's one other paper, one other case report showing a similar thing. So anyway, it's a toy that works. Sorry. So in terms of summing up treatment of air leaks, so conventional ventilation, short eye time, minimal inflation pressure. You do want to probably slow the rate a little bit. Make sure that your expiratory time is adequate, because these lungs tend not to empty. With the oscillator, you may try to use a slower, a shorter inspiratory time. And that pretty much, I think, covered the rest of it already. So let's move on. Let's talk about the troublesome situation of a baby whose chest compliance, whose lung compliance may be relatively okay, but the abdominal pressure is increased, or there's tremendous chest wall edema, or both. And here's a prototypical baby with horrible neck, right? Or it could be a baby post-repair of an omphalocele or gastroschisis. The surgeons like to stuff in the giblets and close it up nice and tight, and the baby can't breathe. So it gets tricky. Especially tricky when the lungs are normal, and that has to do with the fact that the stiffer the chest wall relative to the lungs, the more transmission of pressure to the mediastinum. Here's actually the equation. So floor pressure equals airway pressure times the ratio of respiratory system compliance, or lung compliance rather, divided by the respiratory system compliance. So if, let's say, the baby is on a peak pressure of 30, and the lungs are fairly compliant, let's say a compliance of 2, and the chest wall is very stiff, only 1, which is quite low, which would be appropriate in an older child or adult, but very, very low for a newborn. And so 2 divided by 3, that's 20. That's 2/3 of 30 is 20. So a lot of transmission to the mediastinum. And we did a study many years ago in the animal lab showing that you get better ventilation, but also less hemodynamic impairment with jet than with conventional ventilation. With conventional, you would go rapid rates and low tidal volumes. Ultimate way of doing that, of course, is high frequency. We also had a series of babies that, just a clinical series. These are unpublished data. Babies on conventional ventilation with rising peak pressures and not very good gas exchange, then put on the jet, and rapid lowering of pressure from about 30 to roughly 20 in a matter of 12 hours. But, and again, I don't know what happened to this slide, but this shows the CO2. Use your imagination. So here we had a high and rising CO2, and then we started the jet. And I showed you how fairly rapidly we weaned the pressure, but clearly not rapidly enough, because the CO2's dropped from about 50 to about 25 on average. So I'm saying use transcutaneous CO2 monitor and wean even more rapidly than you think might be appropriate. So there's some magic here, because
I don't know what it is.
This morning the slide was there with everything. I don't know.
Yeah, I saw it before too, so I don't know.
It's bewitched.
Yeah.
Bad karma in here. And then finally, pulmonary hypoplasia. We're getting out of time, so I'll speed up. Well, The problem is obvious, the lungs are small and prone to atelectasis, but also very prone to air leak and pulmonary hypertension. We don't know the optimal strategy, but we think that you want to be very careful about lung volume recruitment, but you don't want the lung totally allostatic. Very gently recruit, because we know that rapid recruitment will worsen pulmonary hypertension, so you want to avoid overexpansion of that hypoplastic lung. Most people go with early high-frequency ventilation. There's some good rationale for that. We looked with conventional ventilation what tidal volume these babies need. We looked at, most people say, well, lungs are hypoplastic, so use 3 per kilo. It's in textbooks and review articles. Well, we tried that, that didn't work. In fact, when we carefully looked at it, babies needed about 4.5 ml per kilo to achieve acceptable CO2. Maybe we could have been allowing a little bit more permissive hypercapnia, but the bottom line is, if you think about it, the baby's CO2 production is going to be the same per kilo whether or not the lungs are hypoplastic. So therefore the alveolar ventilation probably needs to be about the same, and given that they have fewer alveoli, then you are by definition causing volume trauma when you ventilate them as normal tidal volume. Ergo, high frequency makes a lot of sense. Unfortunately, the only clinical trial that was recently stopped, completed because they stopped early, although they had quite a few, several hundred babies, failed to show any benefit. Actually, the conventionally ventilated babies did better. And that may have been a function of how they use the oscillator, because most of us still like to use high frequency. And again, I point to the diaphragmatic hernia. They respond poorly to everything. Jet, oscillator, again, not very good response to anything, including nitric oxide, so go figure. So we don't have magic answers. And finally, of course, airway disease, prolonged time constants, prone to air trapping, other things happen we have to be mindful of. So clearly a different strategy is called for. Look at your flow waveform, make sure your inspiratory time is adequate. It usually isn't. These babies with BPD typically need I times north of 0.5. Few people are willing to go above 0.5, but that's what they need. You need slower rate, longer expiratory time, and you need fairly high PEEP to avoid air trapping. Most people make the mistake of turning down the PEEP when the lungs are overexpanded. Usually in BPD, it's because of air trapping and airway collapse at low lung volume, so you actually need to go up on the PEEP to get it open. So this is problematic. This is what we're dealing with. Very highly variable regional time constants. So you need a relatively slower rate. They definitely have increased anatomic and physiologic dead space. Therefore, they need a bigger tidal volume. We've looked at that, and you need quite a bit higher tidal volumes, sometimes as much as 8 or 10 per kilo. Babies try to ventilate BPD babies on volume targeted ventilation on 5 per kilo. It doesn't work. They switch them to pressure ventilation. Oh, it looks much better. I say, well, what tidal volume are you generating on your setting? Oh, it's 9 per kilo. Well, no wonder 5 didn't work. So the pathophysiology is different, the tidal volume requirement is different. So again, use the tool the right way. It's not the tool, it's us. So I don't know, this pathophysiology doesn't particularly lend itself to high frequency. If you think about it, we tend to use it, we tend to I think the jet has advantages over oscillator in this particular circumstance. A while ago we tried to do a pilot for a randomized trial. We found we didn't have enough of these kinds of babies, so we ended up not quite getting there. But there is some rationale for using the jet because of the nature of the gas flow. You can sort of split the airways, small airways open with adequate PEEP and squirt the gas down there. Without creating choke points. The jet seems to be, gas distribution seems to be somewhat less dependent on regional time constants. Maybe it works. There is a handful of small, mostly anecdotal crossover type studies that suggest an advantage over oscillatory ventilation, where maybe in these poorly supported airways, when you suck too hard, And again, the mistake people make is they see baby on oscillator, BPD, overexpansion, mean airway pressure must be too high, let's turn down the mean airway pressure. When you do that, you end up with negative pressure in the airways surrounded by alveoli that have higher pressure, and you create choke points, and that's probably what's causing the overexpansion. So in fact, increasing mean airway pressure in the face of overexpanded lungs, as counterintuitive as it seems, actually will get the volumes down most of the time. So it's physiology. All right, so bottom line, one-size-fits-all ventilation is out. Individualized patient care is in. It's not just genetics, it's physiology. I mean, you know, we all talking about designer drugs and all that, and that's all great. But we have the ability to do designer ventilation, and we don't. And it's cheap. All you have to do is think about what's going on, consider the underlying disease process, figure out what is the primary problem here, and then you devise the appropriate strategy. But always, always reassess that strategy, reassess the patient's response, because we either may have been wrong in what we thought was going on, or this particular patient just responds differently. So reevaluate at frequent intervals. And so one size does not fit all, be it power volume, be it rate, be it anything else. And you know, what is the primary gas exchange derangement due to? And then tailor the strategy to address that and reevaluate. And finally, you know, the tool that you're using so that you may use it optimally. And this is not a new observation or thought on my part. There was an editorial in Lancet in 1965 that made a similar point, saying that the tedious argument about the virtues of respirators not in